All right, I'd like to welcome everyone to the Vasculitis Foundation webinar today. I'm Kathy Olewski, the host for the Vasculitis Foundation's educational webinar series. I'm also a patient living with MPA vasculitis. These webinars are part of the Vasculitis Foundation's commitment to patient education. And today's webinar is what you need to know about Benralizumab, also known as Fasenra, with Dr. Florence Roufosse. After we finish this webinar today, there will be a recorded version on the Vasculitis Foundation's YouTube channel, and everyone who registered will receive an email with a link to it as soon as it is available. And you will get the link at the end in the email after the end of the webinar. All right, thank you. But before we get started, let me just do a few housekeeping details. It's a live webinar, so we've muted everyone except our guest speaker today. In today's webinar, Dr. Roufosse will do a presentation after her, and after her presentation, you'll have the opportunity to ask her some questions. These questions can be asked by typing your questions into the Q&A box. So if you don't see the Q&A box at the bottom of your screen, click the three dots to the far right bottom where it says more. That you might find it in there. And make sure your question is a general question about Benralizumab as it relates to vasculitis, as Dr. Roufosse cannot comment on your specific medical situation and medication. And I also did want to say, if you need closed captioning, you should look for that box also in the bottom, usually in the left corner where it says captions, but it also might be under the word more. I'd like to introduce our guest for today. Dr. Florence Roufosse is an internist and professor of medicine at Erasme Hospital in Brussels. She specializes in clinical immunology with a focus on eosinophilic disorders. Welcome, Dr. Roufosse. I'm so happy to have you here today, and I would also like to ask you to share any disclosures as we welcome you.
Will do. Okay. Well, first of all, thank you for inviting me to give this presentation about Benralizumab or Fasenra for the treatment of eosinophilic granulomatosis with polyangiitis, which I'll call EGPA from now on for pretty obvious reasons, I think. I'm going to share my slides. Just let me know if you see them. I'm going to put this full screen. Do you see my slides?
Yes, it looks great.
Okay, perfect. I'm just going to see also if I can perhaps make them a bit less gigantic on my screen, but I don't think so. So we're going to continue like this. Okay, so for 25 minutes or so, I'm going to be talking about this molecule, Benralizumab, also called Fasenra, because it's been commercialized, approved and then commercialized for the treatment of asthma for quite a few years now, but specifically with regard to its efficacy in EGPA. So these are my disclosures. There aren't that many. And just a couple key points before we begin, and I think this is really the important part, is, and I as a clinician can really say how different each patient is from the next. And so, you know, these are very, very specific disorders with very heterogeneous presentations and evolution over time. So obviously, I'm going to be giving generalities because I can't address each individual situation with a presentation, but I think it's really important to be aware that one patient is not the other, and treatment responses do differ between patients, as do disease presentations. So before I talk about Fasenra, I'd like to give a few words about EGPA, just to make sure we're all perfectly on the same page, although I'm pretty sure everyone is quite aware of how this disease is defined and how typically it progresses over time. In many cases, but certainly not all, disease actually begins with what's called a prodromal phase, where patients experience pretty severe asthma. It's pretty typically adult onset asthma, but it can occur in patients who did have a history of asthma in childhood that, as often is the case, gets better during puberty. And then there's this kind of reemergence of a very, very progressive form of asthma as they become adult. This is also commonly associated with sinonasal disease, and you can see here the representation of the sinuses where they're projected onto the face, and this can be responsible for very, very bothersome symptoms, including loss of smell, nasal obstruction, headache, et cetera, et cetera. Disease progresses to the second phase, which is called the hypereosinophilic phase, where patients develop both in blood and tissue increased counts of this particular type of white blood cell, which is the eosinophil. Eosinophils are very, very toxic cells when they're activated, and they can release their toxic substances around them in the tissue. And this is really what causes damage, namely in the lungs. And what you see here is a thoracic CT scan where you can see infiltrates, and these infiltrates are really packed with eosinophils that are releasing their toxic substances, and they're damaging the lung tissue here. Those are the first stages of the disease. Just a few words at this stage about what eosinophils are. They're very interesting cells from a scientific point of view, and they're very bothersome from a clinical point of view. Why are they so bothersome? Well, we have different means of defending ourselves against different pathogens. You know, there's bacteria, viruses, and then there's also parasites. And as you can see here, parasites are big-sized pathogens, especially helminths. And what eosinophils do is, rather than englobing the pathogen, like, for example, other white blood cells like macrophages and neutrophils can do, they can actually engulf bacteria, because bacteria are very, very small pathogens. This is absolutely impossible. We don't have any white blood cells that are big enough to engulf helminthic parasites. So what we do instead is we have cells like eosinophils, which are able to recognize these parasites in an antigen-specific way. And when they recognize them, this triggers activation of the eosinophil, which is going to release these toxic substances on the surface of the larvae and really damage it and kill it. And what you can see here on the right-hand side of the slide is bronchial epithelium. This is from a healthy subject, and you can see that normally we have very, very few eosinophils in this epithelial surface, and they're pretty deep below. And it's thought that they may play some physiological roles in tissues like the lungs. But what happens when eosinophil counts increase and eosinophils become activated is, for example, what you can see in patients with severe eosinophilic asthma is the number of eosinophils are going to increase. And you see all these little brown colored cells here. These are eosinophils. And not only that, they're also going to get closer to the epithelial surface, and they're going to damage it. And what you can see here with the laser pointer is you can see the completely destructured epithelial surface, which is really due to the cytotoxic damage, which is induced by eosinophils. Eosinophils, as shown right here, are highly dependent on one protein, a molecule that's called IL-5. IL-5 belongs to a group of molecules that are called cytokines, and interleukin-5 is going to be responsible for increased maturation of eosinophils in the bone marrow, which is where eosinophils first develop. It's going to activate eosinophils. It's going to favor their migration towards tissues. It's going to favor their recruitment in these tissues, and it's going to prolong their survival. So when you have too much IL-5 around, you're basically going to have too many eosinophils, because there's more being born, less dying, and they're being activated by this cytokine. So now that's the eosinophilic component of EGPA. When patients are not treated, they then progress to the third phase, which is called the vasculitic phase. And this is the Vasculitis Foundation, so I'm sure you know all about vasculitis. EGPA is one of many vasculitides, and what you can see here is a typical picture of a small artery which is being damaged by this inflammation, which also comprises eosinophils. There are other white blood cells that are involved, but eosinophils are also critically involved in the vascular inflammation in EGPA. And this is just to illustrate the stepwise progression in these patients. So you can see here, some patients have an atopic disorder, so they're truly allergic, like, for example, to house dust mite or to environmental allergens like beech tree, for example. And then in adulthood, severe asthma develops. Then the blood eosinophilia is going to start to increase. Then and only then, in general, will you see the appearance of the specific antibodies which can be seen in patients with EGPA, which are anti-MPO ANCA antibodies. And then you develop full-blown vasculitic inflammation. The management of EGPA before the advent of eosinophil targeting treatment was, I mean, this is it's a very, very let's say, schematical representation, but more or less, it does summarize more or less what's done in the clinic. There's first an induction phase where the objective is to induce remission, which lasts a certain an amount of time. And then there's the maintenance phase where you maintain the remission. The induction phase, the aggressivity with which we're going to treat the disease is going to depend on the severity of disease. And in patients who have moderate or mild disease, the induction of remission is going to be achieved with corticosteroids alone. Whereas in patients who have severe disease forms, induction is going to really rely on a very, very cytotoxic and immunosuppressive molecules like cyclophosphamide. I don't know how it's called in the States. In French, it's endoxan. And rituximab, which is a monoclonal antibody, which is directed against B cells. Afterward, during the maintenance phase, as you can see here, in the less severe disease forms, it's going to be corticosteroids. And corticosteroids are actually going to be really the backbone of this maintenance phase, whatever the severity of disease. But in patients with severe disease, you're also going to continue less aggressive forms of immunosuppressive therapy, as shown here, with, for example, with azathioprine or mycophenolate mofetil. The problem is, and obviously, asthma being an important part of the disease, optimizing asthma treatment, treatment, local treatment, obviously, inhaled treatment is really very important. The problem is when you try to taper down the treatment during the maintenance treatment phase, generally what's going to limit the ability to completely stop corticosteroids is that asthma and or ear, nose, and throat manifestations are going to recur. And they're extremely invalidating disease features. So it used to be really impossible to taper a large proportion of patients completely off corticosteroids. So this is where the eosinophil-targeting treatment comes in. So what you can see here on the bottom is an eosinophil. On the surface of the eosinophil, you can see the IL-5 receptors. The little yellow ball is the cytokine I was mentioning. This is interleukin-5. And there are two ways to target eosinophils. You can either starve them of IL-5 with mepolizumab or reslizumab. These are monoclonal antibodies which are directed directly against IL-5 itself. And if you starve eosinophils and they're precursors of IL-5, they're not going to thrive. They're not going to develop in the bone marrow. They're not going to survive in the tissue, and they're not going to get activated. So I'm just very rapidly going to show you the results of the initial clinical trials with mepolizumab, because this is the first eosinophil-targeted treatment that was tried in EGPA. And this is a really important trial called the MIRA trial that I'm sure many of you are aware of, which analyzed the response of EGPA to mepolizumab, so an anti-IL-5 monoclonal antibody given every 4 weeks. And what you can see here is patients were able to achieve remission in a significantly higher proportion than patients who are receiving placebo, and a lot less patients receiving active treatment with mepolizumab, so this is the red line here, experienced relapses of their disease during this 1-year observation period. The comparator was placebo, so the patients were not receiving active treatment. One out of 2 patients were receiving placebo. The other type of molecule, the other way of getting rid of eosinophils is with benralizumab. This is what we're going to talk about today. Benralizumab is a monoclonal antibody which is directed against the receptor for IL-5. And when you have monoclonal antibodies directed against receptors, which are expressed on the surface of a given cell, on one hand, you're going to have this starving effect because it's going to interfere with the ability of IL-5 to enter that pocket of the receptor. But more importantly, what's going to happen is the fact that it's really fixing to a surface molecule on a cell. This monoclonal antibody is going to attract what's called natural killer cells, NK cells. And these natural killer cells are going to kill the eosinophils, which have been targeted by this antibody. So this is a very, very active process of killing a particular cell type. So the level of the degree of eosinophil depletion with molecules like benralizumab is more important because it's not just starving the cells, it's actively going out to them and killing them. So what is benralizumab? As I just mentioned, it's a monoclonal antibody which is directed against the receptor for IL-5. This receptor is expressed at very high levels by eosinophils, and they're also expressed by other cells, but a very, very restricted number of cell types in human beings, including basophils, which are also important cells in allergic reactions. But the level of expression is absolutely not on the same level, let's say, the same importance, the same degree as by eosinophils. Eosinophils are the cell which expresses this receptor. It's called Fasenra. Commercially, it's produced by AstraZeneca, and it was developed for asthma quite a few years now, and was approved as add-on maintenance treatment for patients with severe eosinophilic asthma. So it's been around for quite a few years. There's a lot of experience with it. It was more recently approved for the treatment of EGPA, thanks to the results of the MANDARA trial, which I'm going to summarize for you right now. So the MANDARA trial was a more recent trial, which started actually just before COVID, where patients were randomized to receive either benralizumab, which was the new molecule that we were looking into, to mepolizumab, which had already been shown to be effective. This head-to-head study was a non-inferiority study. So if benralizumab was shown to be equivalent in terms of efficacy to mepolizumab, then the study achieved its endpoint. And then we're going to discuss later on this open label extension. But let's first look at the results of this 1-year-long double-blind study where patients received either benralizumab or mepolizumab. They didn't know what they were receiving, nor did doctors, and no one knew what the eosinophil counts were during this period. So the first important outcome was looking at remission. Remission being a patient who has no disease activity, as assessed by a disease activity score called the BVAS, which you probably know about, with a corticosteroid dose. And I'm sorry, this is a mistake here. It's oral glucocorticoid. This should be a C of at most 4 milligrams daily. And what you can see here is a very, very nice equivalence between benralizumab and mepolizumab in terms of achievement of remission. This was almost 60% of patients who achieved remission during these 2 time points towards the end of the trial. And then on the right-hand side of the slide, you can see the breakdown of these 2 components of remission, the BVAS, which has to be at 0, and the glucocorticoid dose, which has to be at most 4 milligrams daily. That's a bit of a detail. This is the accrual of remission over time. So if you look at every 4 weeks, how many patients are actually in remission at that time point, you can see that progressively the number of patients achieving remission increases over time. And around here, after, let's say, something like 28 to 32 weeks, you have a very steady level of patients, which is about 60% in remission. As I mentioned, the level of eosinophils in the blood with benralizumab here in purple is a lot lower than that with mepolizumab, although if you look at what a normal eosinophil count should be, I mean, both molecules achieve very, very nice eosinophil control in peripheral blood. It's just more profound in patients who are receiving benralizumab. A very important endpoint in patients with EGPA is looking at the ability to taper them down or sometimes also off glucocorticoids. What you can see here on the left-hand part of the slide is the dose that the patients who entered the trial required to have stabilization of their disease. And as you can see pretty nicely here, the majority of patients who entered the trial required between 7.5 and 15 milligrams prednisone daily to have their disease under control. This is the median dose of patients when they entered the trial. So patients in both treatment arms required a median dose of 10 milligrams prednisone daily, which is still a pretty high dose in terms of accrual of damage, which is really related to glucocorticoids. And by the end of that 52-week study period, you can see that patients receiving benralizumab, their median dose was only 1.18 milligrams prednisone, and the dose was about 3 milligrams in patients who received mepolizumab. So once again, a beautiful corticosteroid sparing effect in this trial, whichever drug was used. What was interesting also is perhaps to look at the proportion of patients who achieved complete tapering off corticosteroids during this trial. And here there was a slightly statistically significant difference between the 2 treatment arms. You can see that about 40% of patients who received benralizumab were able to taper off corticosteroids, whereas this was true for about 1/4 of patients receiving mepolizumab. Also, sorry, I'm just going to go through my animations here just to just briefly discuss asthma remission, because as I said earlier, one of the key factors which make it impossible for patients who have entered remission for EGPA to taper completely off corticosteroids is the asthma. It's the background asthma, which comes back as soon as you try to taper down the prednisone dose and or the sinonasal manifestations. And I'm just going to show you the bottom half of the slide, because this was another way of looking at asthma remission, which looks more like asthma studies, where you look at patients who don't have asthma relapses, so no exacerbations. They have good clinical control, as can be assessed by the ACQ-6 score. They no longer require background corticosteroids. And despite that, despite the fact that they don't have corticosteroids, their lung function remains stable. And this is a very, very stringent endpoint for asthma control. And what you can see here is that more than a fourth of patients receiving benralizumab were able to achieve this very, very high level of asthma control against 12% of patients with mepolizumab. So this is also a statistically significant difference between the two treatment arms. Maybe I'm going to go quickly here because I can see the time is passing and I would like to have lots of time for discussion, but just very, very briefly, patients were also stratified post hoc, depending on whether there was kind of indirect indices that the disease had been severe in the past prior to inclusion in the trial, because in this trial, severe disease forms were not eligible for participation in this trial. And to make a long story short, looking at these patients who seem to have a past history of disease, which was more severe versus the others, they were equally able to achieve remission, to taper off corticosteroids, etc. So once remission had been achieved for these very severe disease forms, these patients were as responsive to treatment with these IL-5 targeting therapies as patients who had less severe disease. I said I was going to mention the open label extension because these are very, very recent results which have been presented in congresses and which have now been resubmitted in a revised form for a publication. So the data is pretty nice because what happened here is that after this 1 year double-blind period, which is really the study period which was essential to obtain approval of benralizumab for this indication, EGPA, all of the patients were able to enter an open label extension, which gave everyone access to benralizumab open label, so they knew what they were receiving for at least 1 year. And I must say, I have patients that I enrolled in this trial, and they're now in their 4th year, I think, of the study. So the company continued to, on one hand, provide the treatment for these patients who didn't have access to treatment in other forms since it was not approved, but also continue to collect data. And that data is pretty interesting. So just very briefly, so for this 1st year of the open label extension period, which has just been analyzed in detail and which will soon be published, what you can see here is that the patients, so now in the right-hand part of the slide, everyone is receiving benralizumab. And you see the different colors, they represent patients who initially received benralizumab and continued benralizumab versus initially received mepolizumab, and this is the lower line here in blue. And what you can see is that when patients shifted from mepolizumab to benralizumab, they were able to join the proportion of patients who were completely tapered off corticosteroids by the end of that 1 year open label extension period. So roughly 43%, I can't see the right-hand part of my slide, but it's just above 40% of patients completely tapered off corticosteroids. That's really, sorry, oops, here we go. This is also another way of representing the data in terms of patient by patient. You see every single line here is a patient. So from left to right, every line is a patient. And what you can see is over time, the dosing of corticosteroids. The redder the box, the higher the dose of corticosteroids during each consecutive 4-week period. So these are patients who required really, the higher dosing of corticosteroids, and then you can see progressively over time, the lines are getting orange and then yellow and then green, and then these really green lines, this level of green here is 0 corticosteroids. So you can see there's a lot of green. Once patients entered this open label extension, more and more patients who are completely tapered off corticosteroids by the end of that period. So this is a these are very, very nice results in terms of toxicity, accrual of toxicity due to background treatment. So what does it do, this molecule, benralizumab? First of all, technically speaking, it's given every 4 weeks at the dose of 30 milligrams. This dosing is a bit more intensive than that used for severe asthma, because the dose is the same for severe asthma, it's 30 milligrams, but it's every 8 weeks instead of every 4 weeks. It destroys eosinophils. I already told you how. Eosinophil counts really decrease super fast within days. In terms of disease control, kind of depends on the complication and kind of depends on the disease manifestation. Certain disease manifestations get better within days. For example, a patient who has eosinophilic infiltrates in the lungs, like I showed you on that CT scan, and who's breathless and who's uncomfortable and who's hypoxemic, even within 24 hours, that patient is going to feel a lot better. Whereas, chronic asthma, how there's progressive tissue remodeling. Obviously, the benefit may not in all patients be all that rapid. It's same thing with sinonasal problems. Sometimes it takes months before patients will actually be able to experience an improvement. So the fact that things don't get better within days clinically is certainly not a sign that this molecule is not working. The tolerance is really excellent. Are there side effects? I personally experienced this with 2 patients who had very, very high eosinophil counts when they started the molecule. In the evening of the first injection, they had this kind of flu-like symptoms, which disappeared with 1 dose of paracetamol and didn't recur at the next injection. And probably it's considered that this may just be because when you kill like 5,000 per microliter eosinophils all at once, you are going to have some kind of activation of the immune system, but it doesn't last long and it's not serious. It's just uncomfortable for a few hours. Mild injection site reactions, no severe hypersensitive reactions are anticipated, although this can happen with any monoclonal antibodies. So we're very careful for the first 2 injections, but afterwards patients can do them on their own at home. No increase in incidence of infections and cancer. So there are really no serious matters of concern. Perhaps practically speaking, also, given the fact that eosinophils are thought to be important for protection against helminthic parasites, it's recommended that we check as physicians that patients are not infected by a helminth before starting, and if so, first treat the patient, and then you can start using these eosinophil-targeted therapies. Treatments are super easy, they're super good, well tolerated, so sometimes we even give them if we're unsure that the patient has ever had a risk of having one of these helminthic infections. No specific monitoring is recommended. There's very, very little information so far on use during pregnancy. There have been a few accidents, meaning some patients who became pregnant while receiving treatment, and these accidents have actually turned out pretty well for both the mother and fetus. And probably, as you know, severe asthma, at least, is in itself a risk for pregnancy. So having a better control of asthma may be a better thing than having active severe asthma. So these are data that are being collected right now for the future, for future knowledge. There's no specific treatment for an overdose, and this is just what the auto-injector looks like. There's this little plunger head here, and you can hear a little click when the complete dose has entered the body, and it's very easy. It's for subcutaneous use. For now, who is eligible for treatment in terms of approval? So just by the way, it's approved. It's still not commercialized in Belgium. We've been waiting for a couple months now. It's going slowly, but if I'm not mistaken, in the United States of America, you can buy it and you can use it already. Please correct me if I'm wrong. But the patients who are eligible are patients with EGPA adults. So this is 18 years and above. Patients must fulfill what's called the MURA criteria. So the criteria which were used to enter patients in that very first clinical trial with mepolizumab that I mentioned, meaning that at minimum, the patients have to have asthma. They have to have elevated eosinophil counts within the range which is shown here on the slide, plus 2 additional features of EGPA. We can discuss that if it's interesting for you. But these features include, for example, sinonasal problems, lung infiltrates, like I showed you on the CT scan, et cetera, et cetera. Disease has to be relapsing or refractory, and patients have to require maintenance glucocorticoid dosing, or, and that's a pretty easy one, unacceptable side effects, poor tolerance. I mean, who tolerates corticosteroids, right? So it's pretty easy if we have this type of indications, this type of criteria, we can always argue the tolerance is poor. So this is a pretty easy one. The future of benralizumab, there are studies that are ongoing, for obvious reasons in eosinophilic disorders. For example, the hypereosinophilic syndrome. This is a disease that I see a lot of personally in my practice, and there's a clinical trial which is still ongoing called Natron. COPD, you can see other forms of nasal polyposis here, chronic urticaria, et cetera. And as I mentioned, we're also there are also ongoing studies trying to accumulate data on pregnancy exposure to benralizumab. So my take-home messages are the following. This is a very complex disease. Pathogenesis is super complicated. It's different from one patient to another. But one thing is absolutely undeniable is that eosinophils are part of these pathogenic mechanisms. So it's very interesting to be able to target them with treatment. Many patients are corticosteroid dependent once a remission has been achieved. And this is often because of the asthma and the sinonasal problems. Reducing or stopping oral glucocorticoids have been shown in several studies. There are major incentives for patients who suffer from these chronic inflammatory diseases. As I showed you just during the last 15 minutes or so, targeting eosinophils does enable reduction of background glucocorticosteroid use and while maintaining disease control. And for a subset of patients with EGPA, this even means complete withdrawal of background glucocorticoid treatment without decreasing lung function, without symptom relapse, and so continued disease control. These are the different organisms which support my interest in eosinophilic disorders. I'd like to thank you for your attention. I hope we're going to have an interesting discussion, and then I'd like to end and leave posted this slide about the resources which are recommended by your society.
Okay, thank you so much, Dr. Roufosse. We are going to take questions, and if you wouldn't mind, you can go ahead and stop sharing your screens. Everybody will get this link as a reminder as soon as it's up on the YouTube channel, so you can find all this information again after the fact. And it's great that it's all compiled in one area. I did want to say before we start taking questions that Dr. Roufosse cannot comment on any personal medical questions. So if you've asked a question about specific medication dosing for a particular problem, she's not going to be able to comment on that. And so try and make them general questions about the Fasenra, so that you can educate all of us about Fasenra. And having said that, we've got quite a few questions in the question and answer box, so I'm going to start with them. The first one, interestingly, by the way, I wanted to say everything about that MANDARA trial was just fascinating, so I appreciate you educating us on all of that. The first question is it common to switch between Fasenra and other biologics during the course of EGPA?
So first of all, nothing is common in EGPA because it's not a common disease, obviously. But I mean, for sure, it happens. So different ways around. So obviously, I'd say that the first thing to answer is these eosinophil-targeting biologics. As I said, they're really used mainly for the asthma management. So obviously, many patients over the years have been receiving, for example, omalizumab, so that's Xolair, before these drugs were out, which target eosinophils. And so, yes, they certainly have since then been shifted towards these eosinophil targeting agents. And there are even some other agents now that have proven effective in eosinophilic asthma, which are also beginning to be tested in EGPA. So I think that from an individual patient perspective, what's interesting is to have this kind of spectrum of different molecules that we can use. We can switch from one to the other. What's going to work for one patient is not necessarily going to work for another, as I said earlier. And there's more and more a tendency now even to combine these biologics. Like, for example, targeting eosinophils on one hand, but also targeting, for example, let's say, higher levels, more upstream levels of type 2 inflammation, like, for example, dupilumab or tezepelumab, which are different agents which are also used for severe eosinophilic asthma. There's more and more tendency not only to shift, but also even to combine now.
Very interesting. And I know that you went over clearly in the presentation, but for somebody who's new to EGPA, it's also very confusing. And someone is asking if you could just restate what eosinophils are.
Okay, so they're white blood cells. They're not very highly represented in the blood of healthy subjects. So it's like less than 5% of the white blood cells that someone who's not allergic, let's say, and someone who doesn't have an eosinophilic disorder. What they're there for physiologically, it's thought to be at least contribution probably to defense against these helminthic parasites, although there is some controversy about that nowadays. And also, I mean, we're only beginning to understand what they do in human beings, in healthy human beings. I mean, this is very, very novel, a novel field of interest. It's called homeostatic eosinophils. We know lots of what they do in mice, very little about what they do in humans. So that's it. It's a white blood cell. It's poised at our interfaces with the external environment, so in the digestive tract, in the lungs, probably to have some kind of physiological function there.
Okay, thank you so much for restating that. It helped me, so I hope it helped our other viewers.
Okay. Sorry.
Next question is, how quickly do patients typically see improvements in symptoms after starting Fasenra?
So I really briefly mentioned that on the slide, and it's a really important question. What I already said is that clearly depends on the symptoms. And as you know, EGPA symptoms, there are so many different symptoms. Let's start with the tough one, fatigue.
Yeah.
It takes a while. It really takes a while. But what I can say for sure, I don't know where the analyses are for now in terms of the MANDARA trial. But what I can say for sure, and this was an amazing result in a trial on hypereosinophilic syndrome using mepolizumab. So we're in a different disease and a different molecule. We're looking at this anti-IL-5 antibody in hypereosinophilic syndrome. Hypereosinophilic syndrome is very similar to EGPA for certain aspects, because it's also eosinophilic inflammation, which can go in the lungs, the heart, digestive tract, etc. So lots of overlap between these disorders. And what was beautiful with the mepolizumab trial at the time is that we looked at fatigue, and it was a pretty short treatment period. If I'm not mistaken, it was like at 32 weeks, there was a significant difference between the severity of fatigue in patients receiving active treatment versus placebo, which is pretty amazing. It's rare that you see improvement of fatigue in chronic inflammatory disorders. So I think that even with that tough one, it's not something that you anticipate is going to get better very rapidly, but with active treatment, progressively, patients are going to feel less fatigue. This is going to take a while in general. Let's look at the things which can improve very rapidly. When you have hypereosinophilic flare in an organ, for example, I showed you the CT scan of lungs of a patient with hypereosinophilia and in lung and tissue and the blood. When you have eosinophilic infiltrates like that, you're very, very breathless, very, very uncomfortable, even when resting. If you have one shot of mepolizumab or benralizumab within hours, and for sure the next day, you're going to feel a lot better.
Wow.
Same thing if you have, well, I mean, that's what responds the best, let's say. If you have a very, very hypereosinophilic inflammation somewhere, for example, the skin, the digestive tract, something very, very active and mainly eosinophilic, it's also going to feel better very quickly. What's different is when you have these more chronic symptoms like asthma, sinonasal manifestations. If you look at the airways in patients who have sinonasal manifestations, you do a CT scan, you're going to see this massive thickening of the sinonasal lining. This is not going to disappear in 24 hours. This is going to take a long time. And even when eosinophils disappear, you still have all this extracellular matrix, you have fibrosis, you have other cell types. So this takes a while, but it does improve in many patients. Same thing for asthma. If you look at the airways of a patient who has asthma, you're going to see remodeling. You're going to see a thickened airway. You're going to see an airway where there are more smooth muscle cells than you see in a normal airway. So obviously, just getting rid of eosinophils is not going to do the trick within 24 hours. It's going to take months, often, for patients to really experience a benefit. What you're going to do is you're going to see there are going to be less exacerbations of disease, which is typical of severe asthma, but you're still going to have this kind of background asthma, which from time to time can fluctuate in severity. So I'm not sure if my answer is super clear, but when you have something which is very inflammatory, very acute, very eosinophilic, only eosinophils in the tissue, it's going to get really, really quickly a lot better. The more chronic manifestation is going to take more time, but you do see these improvements all the same. So you have to count that in months, I'd say.
No, I think that was very clear. I think that's super helpful to most people. I'm going to combine a couple of questions here based on what you just said. There's a question here about what are the most common side or adverse effects events reported with Fasenra, and somebody also is asking, can joint and muscle pain after being on the medication for eosinophilic asthma and then changing to EGPA? And I guess they're saying, what are the side effects, and is one better than the other because of that?
So the reported side effects that you're going to see in the sheet when you buy the actual molecule, for example, the most frequent was COVID. I mean, why? Because the study started during COVID. So so obviously people were getting COVID, and the drug does not increase the probability of having COVID. The same was seen in patients who were receiving, placebo or mepolizumab in whatever trial. But this is due to the moment when the trial was run. Other side effects are like, for example, asthma exacerbations or headache or sinusitis. Once again, why? Well, because these are manifestations of EGPA. And obviously, when you're treating patients with a treatment which is not going to improve these manifestations immediately, patients are going to continue from time to time to have complaints in those systems, which are part of their disease. So this is why you're seeing manifestations like asthma, headache, sinusitis coming up in the adverse events list for these molecules. It's related to the nature of the disease which is being investigated and its natural course. And despite the active treatment, you do see some emergence of these symptoms from time to time, albeit less frequently than without the drug. So this is just kind of to let you know how to interpret adverse events as they appear on a notice, for example. The question about muscle and articular pain is an important question. It actually happens in many patients in my experience, but why is that? It's because I taper corticosteroid down. And so when you taper down corticosteroids, it's almost systematically experienced by patients is to have muscular and joint pain. Sometimes it's due to full-blown, outright adrenal insufficiency, because if you've been taking corticosteroids for many years and then you stop, well, sometimes your own adrenal glands can't take up where they left off many years ago. So that can be really one cause of muscle pain and joint pain. But besides that, just the fact that you're decreasing corticosteroids, which, by the way, do help if you just have osteoarthritis. And, patients with EGPA, if you look at the median age, it's 50 years old, roughly. So who doesn't have a bit of osteoarthritis at that age? So saying that these adverse events which patients experience is really related to the drug, I would not say that as explicitly. Could be, but my experience with patients is that they can continue with benralizumab or mepolizumab, having these complaints, and then at some point the complaints are going to disappear because their body has gotten used to no longer being treated with corticosteroids on one hand, or because in the meantime, the pain is centered at a given spot. I investigate that and figure out that they also have some other problem. Like, for example, I don't know how this articulation is called in English, I'm sorry, but they have calcifications in the shoulder. This is super frequent in the general population, especially if you do some form of manual labor. So I think, for sure, lots of patients are going to experience these undesirable symptoms, but you have to think about how it can be related to corticosteroid tapering, either directly related to that lack of corticosteroids, but also related to the fact that's going to reveal the fact that for other reasons, we can also experience articular pain. I don't know if that answers the question.
Yeah, I do think it did. And we have such a variety of questions. I'm going to try and move on to some other topics. There are two questions about related to ANCA. So one person is, how does a patient's ANCA status affect the decision to use Fasenra? And another patient is saying, you mentioned that Fasenra can be combined with other biologics. Would that be more geared towards ANCA plus EGPA, like rituximab or something?
Very interesting questions as well. So for now, there aren't any official recommendations in that particular field, but it certainly is the object of a lot of interest. So indeed, there's this kind of notion that patients who have ANCA in the setting, so it's about 1/3 patients with EGPA who have ANCA, those are the patients who are going to experience more vasculitic manifestations. First of all, that can be true statistically if you're looking at percentages of patients. At the individual patient level, it's not true. Some patients who are ANCA negative are going to have typical vasculitic manifestations and vice versa. So if you look at the individual point of view, that rule is not predictive for a given patient. And yeah, you're right. There's certainly the possibility of combining treatments which are going to try to target the more autoimmune component of disease. And there are some studies which seem to indicate that patients who are ANCA positive, these are the patients who are going to benefit most from rituximab, versus those who are ANCA negative are going to benefit most from mepolizumab, for example, and now probably benralizumab. These are obviously, once again, they're just statistical notions. There's a nice study which is ongoing now in France where patients are being treated from the onset of disease. So they arrive with acute disease, including disease with vasculitis, and they're being randomized to receive either mepolizumab as first-line treatment or classical immunosuppressive treatment with rituximab or cyclophosphamide. And this is probably going to answer the question that's being asked, which is a very pertinent question, but we can only say there are case reports out there. One thing for sure is that eosinophils are part of the vasculitis. There are eosinophils in the vessel wall, and we know for sure that eosinophils can cause damage to blood vessels. So maybe we won't have to combine with these classical immunosuppressive agents. This is something we should know maybe in a year and a half from now, thanks to the French trial.
Okay, that's great news, something to look forward to knowing. Somebody's asking, are there any long-term safety concerns with Fasenra? And I know it's been used in asthma for a long time. So is there information on that?
Yeah, so I mean, all the information we have is super reassuring. There are no long-term safety concerns so far. And I mean, long-term safety concerns, what are they about? They're about infections, they're about cancer. And so far, there are no signals that seem to indicate that those kind of adverse events are impacted by treatment. Those are important adverse events when you're giving immunosuppressive treatment to patients, obviously, because you're decreasing the general immune system response. And what is it there for, the immune system? It's to defend us against microorganisms, pathogens, and cancer cells. But if you're targeting a very specific cell and that cell doesn't seem to contribute all that much to that form of defense, or maybe it's being replaced by other cell types if it's not there. Well, I mean, that might not be an issue. And so far, so as you saw, Fasenra has been approved since 2017, and if I'm not mistaken, mepolizumab, it's been 10 years now, since 2015, same type of molecule. There are still no safety concerns in terms of long term. But I mean, obviously, we're still very vigilant. Maybe 10 years is not enough when considering cancer, etc. So obviously, this information is still being collected as usual when new molecules come out. But it's not like, for example, anti-TNF, very rapidly, it became very clear that there was too many cases of tuberculosis. That was super fast. This has not happened with either mepolizumab or benralizumab.
Well, that's great news for all of us. I know that you did touch on in the study a little bit about people that have been accidentally exposed to Fasenra during pregnancy, but there's a question specifically, is Fasenra safe to use during pregnancy or breastfeeding?
So I can't answer that question, unfortunately.
Right.
There's data that's being collected right now. As I said, this is true for many chronic inflammatory disorders. These disorders in themselves represent a risk during pregnancy. Depends on the disorder. There are many different chronic diseases, but for some, it's well known that the pregnancy outcomes are less good if the disease is not controlled. This is the case for asthma, severe asthma, for example. So, I mean, these are, as usual in medicine, it's benefit risk, and then if we can come with the science in addition to that, the evidence, and that's collection of data on what happens in the real world, well, that's even better. And so that's ongoing. That's something that's being done right now, but we still have not enough evidence, scientific evidence, to be able to make a statement about that. What I can say, and I think this was with benralizumab, and I think it's published as a case report. Amy Cleon, who's well known in the States, she works at the NIH and she treats patients with eosinophilic conditions. She really has a referral center for that. She had a patient, I think with benralizumab, who was in a trial, who decided to continue it when she accidentally became pregnant, delivered a healthy baby who had no eosinophils, which is not normal, obviously. But they eventually came back, these eosinophils. It took a long time, but so that baby has been followed and then became an infant and then a child, has had absolutely no health concerns, and eosinophils eventually came back. But the baby was born without eosinophils.
Wow, that is so interesting. It
We
makes
need
sense.
more.
It makes sense, but just
Yeah.
so happy that well, I'm glad they followed that situation to let us know that. That's interesting. I feel like these next two questions, that I'm gonna combine, are not something you can answer, but I'm gonna put them out there because didn't you say that it's not approved in Belgium yet for treatment?
So approval is acquired on a continental level. So it's
Yeah,
approved for sure. Afterwards, each state in Europe has its own rules and how it's going to be reimbursed, how much it's going to cost, and that's a lengthy process.
right.
And so I think it's been more than 6 months now that I gave as an expert my opinion on the reimbursement criteria. We're expecting it any day now. So approved, it's been approved. It's just all about reimbursement and patient access.
Yeah, so the questions were probably referencing the United States, but they were, what steps can healthcare providers take to improve insurance approval for Fasenra for EGPA patients, and what documentation is typically required? I think we're going to have to find out those answers for you and see if we can help with that. I don't think Dr. Roufosse has those answers today.
Yeah, I mean, in Belgium, once we have the reimbursement criteria, it's going to be like 10 euros a shot for everyone.
Wow.
But we still don't have them.
Okay. And we're getting close to the very, very end here. So I just want to ask you from our viewers, there were a lot of questions. So is it possible that we can get you to do a recorded, answer some of these questions later down the road? We'll tag this onto the YouTube channel of the live presentation, if that's okay with you.
We'd be absolutely fine. I'd do that with pleasure. Yeah, after
Okay, then we'll get back with you about working through that. Thank you so much for that. And I wanted to tell everybody before we wrap up today that we wanted to remind all of our viewers to visit the Vasculitis Foundation website for more information. It's very helpful. And I'm going to share screen if I can do this properly today. There we go. And I just wanted to say that the Vasculitis Foundation website is where you can find all kinds of information to help you about all kinds of vasculitis. As you know, or may not know, there are so many forms of vasculitis. And as a matter of fact, after you've read about all your particular form of vasculitis, you can go to the resources tab, and under order print, you can find short documents that you can print out for family, or even take with you to your next primary care doctor's office visit, which is what I do. When I saw my eye doctor recently, I printed out my type of vasculitis and took it with me so that she didn't have to wonder if she had all the relevant information. And on the Vasculitis Foundation website, you'll also find the video library where all of these webinars are contained. And I'd like to let all of our viewers know that also today, when you leave this webinar, a survey will pop up. And in this survey, we want to know basically how we're doing in this series. And as soon as the webinar is done, you'll see that pop up. So click the word continue, please, to take that survey for us. We would greatly appreciate it. I also wanted to thank everyone on the, thank Dr. Roufosse for your time today, and remind everyone that you'll get a copy of this webinar link as soon as it's available. I forgot I wanted to share one more thing here. So thank you so much to Dr. Roufosse and the Vasculitis Foundation for providing these medical educational webinars. We're so grateful for that. And we, of course, we know how important your time is, Dr. Roufosse. So thank you so much for being with us today.
Thanks a lot. It was a pleasure. Have a nice day, everyone. I think it's
all right. Thank you,
still have
everyone.
a day ahead of you, so have a nice day.
Yes, and thank you. Don't forget, click continue and take the survey for us. Thank you.